Hi guys, welcome to today's episode of Feature of the Day. Today, on 1st of April, apart from it being an April Fool's Day, is also Lupus Awareness Day. And I thought, what better an occasion to talk a little bit about SLE, that is systemic lupus erythematosus in pregnancy, other than today. So, there are multiple facets to SLE. Lupus in general tends to flare up during pregnancy is something that almost everybody knows who has seen a patient of lupus erythematosus. The reasons are plenty. The major immunological reasons include that there is a shift of immunity from TH, the helper T cells from TH1 to TH2. There is also a significant change in the complement levels and the B cell immunity. Also, there is a hypothesis that the increasing prolactin levels play a significant part. Apart from all the hormonal changes of estrogen and progesterone, they all play a significant role in causing flare in lupus erythematosus. So, most often these flares are hematological, they affect the hematological and the renal system in the body. Often, a lot of patients are already having an active disease. They are not currently in remission, in other words, and they tend to conceive. This is something that should be avoided, and often the pre-pregnancy or rather pre-conceptional counseling should consist of deterring these women to conceive until they're at least 6 months free from any active disease interval. So, what are the different things that we need to see with various stages of pregnancy in lupus is what we'll summarize today. So, the first scenario is if a female has come to us in a pre-conceptional stage, then first of all, I would like to ask her about the drugs that she's consuming in a later, or rather, I'll just do it now. If I'm going to be talking about drugs, there are few drugs that are given during lupus. Those drugs, few of them are contraindicated, while few can be given. So the ones that can be given, the most important one is hydroxychloroquine. Hydroxychloroquine has time and again proven to be good and compatible with pregnancy. And do not mistake it with hydroxyurea, which is teratogenic and needs to be stopped at least 3 months prior to pregnancy. But hydroxychloroquine definitely can be given preconceptionally and even after conceiving. After that, 5-ASA or sulfasalazine can be given. Azathioprine, a very significant drug, a drug that often people tend to stop. It's a steroid sparing drug. Basically, it means that the total dose of steroid or prednisolone that is being given will be reduced when you give this drug. It's a disease modifying agent as well in this disease. Apart from that, tacrolimus and prednisolone in low doses is known to be safe. Although there are reports that prednisolone can cause cleft lip and cleft palate, but the risks are not that significant, and all of it can be ruled out, or all of that can be captured by doing a good malformation or second trimester anomaly scan. But the drugs that definitely need to be stopped several months prior to conception include mycophenolate mofetil, which is very significantly given. So MMF, that is mycophenolate mofetil. Also leflunomide, which is another drug that you may have read in multiple sclerosis, is a drug that is teratogenic that needs to be stopped. Methotrexate, absolute contraindication. In fact, methotrexate is one of the drugs that we give for medical management in ectopic pregnancy. So it is definitely toxic to the trophoblastic cells. It leads to things like clover leaf skull and skeletal defects. Cyclophosphamide is yet another drug that needs to be avoided and has to be stopped prior to conception. These are also the drugs that cannot even be given during lactation. These drugs can cross the ductules and can go from breastfeeding to the baby. So these need to be stopped. There are few drugs that need to be stopped preconceptionally but can be given during breastfeeding. They include drugs like rituximab, which is a anti-CD20 receptor blocker. So apart from asking her what are the drugs that she's consuming in a pre-conception counseling, I'm going to be testing her for Apla syndrome. Now, Apla syndrome, when it shows up during her bouts of SLE is known as secondary APLA. So I'd be definitely testing her for lupus anticoagulants, beta-2 glycoprotein, as well as the third antibody that is the anti-cardiolipin antibody. So apart from lupus anticoagulants, if there is a high to moderate titer of the other two, that is anti-cardiolipin antibody and also beta-2 glycoprotein, these women are having APLA syndrome, or if I can say secondary APLA, and they need to start taking heparin prior to conception because there is going to be a high risk of thrombotic event and even pregnancy loss associated with this. Apart from that, if the female already has end organ damage, things like pulmonary hypertension, pulmonary fibrosis, or cardiomyopathy, or if she has classical Libman-Sachs valvular involvement of the heart, that is Libman-Sachs endocarditis, she has to avoid getting pregnant. Also, if the female is having CKD, that is chronic renal disease, she definitely has to avoid conception, and pregnancy is contraindicated in these patients. Her blood pressure monitoring definitely needs to be done. A lot of these women are going to be chronic hypertensives, and a drug that is non-teratogenic has to be started for these women. Apart from that, a very significant point is that we have to test these women for SSA and SSB, that is systemic sclerosis A and systemic sclerosis B antibodies. These were earlier called as anti-Rho and anti-La antibodies. Now, if you can remember that you must have read in your final year in Harrison's that these are the antibodies that cross the placenta and increase the risk of causing neonatal lupus. Neonatal lupus can be in two forms. It can either be cutaneous or cardiac. That we have read has been affliction in which there is heart block because these antibodies go and attack the conduction nervous system of the heart. So these cause prime first degree, second degree, and third degree heart block. And third degree heart blocks might even need pacemakers. So it needs to be checked that these antibodies are present or not. Once she conceives, I again have to review the drugs that she has been taking and the ones that can be continued. If she has Apla syndrome, then she needs to be taking heparin from first trimester till 6 weeks after delivery. For end organ damage, definitely a medical termination of pregnancy has to be advised. So if this is the case, MTP is advised. BP monitoring continues. Drugs, preferably labetalol and nifedipine are given. These patients towards our late first trimester are started on aspirin. The ideal recommended dose is 81 milligram per day, but we do not get those doses, so we prefer to give 150 milligram per day. It is also useful because these people have endothelial dysfunction, and this prevents that endothelial dysfunction from causing aggregation of platelets. In second trimester, these women are at a very high risk of developing preeclampsia. So I have to be checking for the urine albumin. I have to be checking for the uric acid levels. Now, an acute flare of systemic lupus erythematosus and HELP syndrome or severe preeclampsia can look very much similar. The differentiating point here would be, first of all, I'd be seeing their WBC counts. So the WBC counts have to be seen. I'll also be checking for the transaminases. The liver enzymes will never be elevated in systemic lupus erythematosus. So I'll be checking for that. So basically, all the end organ damages specific to preeclampsia will be increased only in preeclampsia, not in erythematous lupus SLE, the main ones being transaminases and WBC counts. Apart from that, fetal 2D echo is very essentially done in patients who have SSA and SSB antibodies to look for cardiac blocks. In fact, for women who have both of them positive, you need to be doing a weekly fetal 2D echo because that is going to help you finally recognize if a baby requires any intervention for its heart block. Finally, a good malformation scan, because these women are often going to be consuming teratogenic drugs, so it is preferable that a good detailed malformation scan is done. Finally, in the third trimester, what we need to look out for is fetal growth restriction and IUGR. So, a monitoring by doing Doppler is very essential. These women have a very high thrombotic potential, so the uteroplacental perfusion is always going to be impaired. Also, with a very high risk of preeclampsia, it is yet another reason why there is going to be IUGR. So, to prevent intrauterine fetal demise, I need to be doing this. Post delivery, these women have a very high thrombotic potential and they often have thrombotic events. So, it is preferable if these women receive anticoagulation. Finally, if the mother had SSA and SSB, the baby after delivery has to be again checked for cutaneous as well as cardiac lupus affliction. And finally, the patient can be discharged. So I hope you understood this brief overview of systemic lupus erythematosus in pregnancy. Do follow us more for more such features. Thank you.